Hey guys, it's Dr. Dobson, and in this one we're going to be going over a very interesting implant case that we did. So here's a before and after, but the very interesting thing was actually in the case workup. So here's an x-ray. The patient presents with pain in the upper left. The x-ray would suggest that the 2.5 is the problem tooth because of the massive lesion that you can see at the root tip. But when we did our clinical testing, we noted that the 2.5 was actually perfectly vital to EPT and cold, and the 2.6 was completely necrotic. We almost made the decision to endo and crown both teeth because I thought that it was a false positive on the 2.5 and that the lesion was super obvious, but something didn't add up. So I actually had a gut feeling to refer the case to endo. So that's what we did. Referred the case. About a month later, I got the specialist note saying that 2.5 is perfectly healthy, 2.6 has a root fracture, and it's actually a cyst around the 2.5, not a sinus, not a lesion. So we made the plan to extract the 2.6, do a massive cystic curettage. It was a huge cyst cavity with a very large round carbide on the implant handpiece under saline irrigation, and then placed a bunch of bone graft material. So here's an x-ray directly after that appointment, and you can see the bone graft material in place. We waited just 4 months, and we saw that the lamina dura had returned to the 2.5. Lots of good, healthy trabecular bone fill. The 2.7 had migrated measly a whole bunch. And then we decided to place an implant at this point. We placed a 4.8 by 10 millimeter tissue level into the area. It was pretty thin, but we got a good placement. And from here, we're good to go. So 3 months later, we get the patient back. We take a scan with the scan flag in. I'm going to send the scan to my designer. He's going to send me back the STL file that I'll put into my Roland. Here's the STL nested in the block of monolithic zirconia, argons at STML. I'm going to mill it, sinter, polish, and then bond the adapter or the abutment into the cavity. And then we're going to get the patient back to install the crown. So we'll take off the healing cap with the torque wrench, remove the healing cap. The tissue looks nice and healthy. You can see how much the 2.7 has drifted in just a very short period of time. But we'll put in the implant crown, happy with the fit. Octagonal platform, I love tissue level. There's the x-ray after we had torqued it down to about 15 or 20 Newton centimeters, and everything looks perfectly back to normal. So we'll check the contacts with floss, and we're happy with everything. The bite was good. So we're going to wrap it up and backfill the screw channel access with some Teflon tape and then flowable. And that's pretty much this one. The 2.5 is still vital. The implant crown's happy. Area is asymptomatic at this point, and that was a successful case. So thanks for watching this one. That was my first cyst curettage treatment. And if anybody has questions, feel free to leave them in the comment. Big shout out to Dr. Luke from Ohio for editing this raw footage. If anybody else wants to help edit raw footage, I have a massive Google Drive full of every kind of case you could imagine. And I just need help trimming down the raw footage into usable footage so that I can narrate them.